So waiting for that doorbell to ring. So this was an article that has, like many of our articles, has been vetted by ASAM and is being used in their maintenance of certification process. And I just thought it was a fascinating and kind of a well done article. So that's why I picked it. And, it's sort of a randomized controlled trial that's not done with medications, but is rather done in terms of like a systems change. So that was also interesting. So following along, and I hope you can see this this template. This is sort of, whoa, it's too much. This is the template that we created for the journal club process. So you have the citation there. This is coming out of Washington State, specifically the College of Medicine at Washington State University, as well as the Washington State University College of Nursing. So both of those places. And the question that the article asks is, will the care of patients who visit ERs frequently improve through the use of a care coordination program as measured by reduced ED visits and reduced controlled substance prescribing? And so the other question is, do I care about the answer to this question? And yes, I do care, because many patients with opiate use disorders, including some of my very own patients, are frequently seen in local ERs. And I see that coming up in my computer, and sometimes they just tell me they were in the ER. And I am concerned that some of them may receive inadequate care at times. And number two, I do care about system change and system improvement in my community. And if this is something that Washington State has done, it always makes me wonder if it's something that could be replicated in my own backyard. So, and again, this is not meant to tell you sort of every single detail of the study. It's presumed that most of you have read the study. This is just meant to be a guide to walk us through some of the high level things. And then what I hope is that we have a great discussion about it. So the next question is, does the study design permit valid results? Another way of asking the question is, how well was the bias eliminated? So let's take a look. This was a multi-site randomized controlled trial across all emergency rooms in a metro area. Took place in Washington State. It was 135 miles southeast of Spokane, Washington, and they were able to basically work with every single emergency department in that tri-city area, as they called it. And what they did, even though the paper was published in 2016, the data were collected in March of 2012 to July of 2012 is when they enrolled patients. And then patients in the intervention group were followed up for 1 year. So then the study ended up ending in July of 2013. So this is a ways back now, 8-9 years ago, but they did look at 165 patients, which they then divided into two groups, and they had two primary outcome measures. They were counting number of ED visits, and they were also counting the number of controlled substances that emergency room physicians were prescribing, specifically looking at opioids. So who did they actually study? And is it similar to any of the people I see here in Northeast Ohio? I would say yes, it is similar to my population with respect to age and gender. If I remember correctly, the average age was 37 and 62 or 63% were female. And the way that it is not similar to my population is that, I work in a densely populated part of Cuyahoga County, which has millions of people. And I think they said their area had approximately 250,000 people in a tri-city, they called it a metro area. To me, that's kind of more rural, but I guess it's all a matter of perspective. So I realized as I wrote rural, I'm like, that's not exactly rural either. When you looked at the two groups, they did not differ from each other on gender, age, number of ER visits, or number of opioid prescriptions from the ED. You were included in the study if you were greater than age 18, if you had 5 or more ED visits in the last year, and if half of your ED visits were attributed to pain, or what they called drug-seeking behavior. You were excluded if you had some sort of terminal diagnosis that the investigators thought would be unsafe for you to be included. You were also excluded if you had a cancer diagnosis, if you were acutely suicidal, and if you had a high ED utilization for a medical reason other than pain. And the example they gave of that was like chronic inebriation. So if you're, I guess, getting drunk every week, they weren't going to include you in that. When you looked at the study population, every single one of those 165 patients actually had at least 11 ED visits in the year before the study. So they way surpassed the 5+ ED visits. And so these are folks that, I know we're not supposed to use the word frequent flyers, but these were folks that were coming into the ER about once a month. So kind of almost like primary care office, or even more frequently than most people would use their primary care office. One of the things that I thought was interesting in the first couple of pages of the study was that they were able to get a waiver of consent from their IRB, and participants were actually not informed that they were in a study. So I was like, really? You can do that? Because what they were afraid of was that being told that you were in one group versus the other might skew the patient's understanding of whether or not they might get an opioid prescription or not. And so I just thought that was a really interesting thing that was talked about right at the very beginning. The last part of this section is whether or not the outcomes that they looked at were reliably measured. And in my opinion, yes, the outcomes that they were looking at were exactly what they said they were going to look at. They actually counted number of ED visits, and they actually looked at controlled substance prescribing. And I thought that using their hospital EMR system and using the Washington State drug monitoring program, like their ORS program, were reliable sources of information. So what did the study actually show? What are the results? And what does this actually mean? So if you have your article on your computer or in your hand, you can recall that on page 16, table 1, the baseline characteristics, as I already stated, did not differ between the groups. And then if you look at page 15, figure 2, which is one of pretty much the only graph that they showed us, and page 18, table 3, what you will see is that the intervention group showed a 34% decrease in the incidence of ED visits versus the controls. And when you looked at actual hard numbers, because I was actually wondering what the numbers were, so there was a mean over sort of the life of the study of 5.59 ED visits from the intervention group versus 8.49 visits in the control group. And that was significant at a level of less than 0.003. And it was also, interestingly, less than the average of 11+ visits that they all had. So whether or not you were in the intervention group or the control group, ED visits decreased for everybody that was in the study, which might just be part of that bias of, whatever you study actually changes just as a result. What's that called? Hawthorne effect or whatever, one of those effects that you learn about in school, where when you study something, it changes just as a result of actually being studied and not as a result necessarily of the intervention. So interesting finding. And then also, and probably most interesting, was that on page 18, table 3, the intervention group did show an 80% decrease in the odds of receiving an opioid prescription from an ER provider. And so that was a mean of 0.28 versus 1.44, and that was also at least statistically significant. So what does this mean in English? It does seem to show that when you do a citywide care coordination program combined with a emergency department care coordination information system, you can reduce ED visits and controlled substance prescribing by ED providers. What we don't know, and of course, every study has its limitations and you can only do so much. They did not know if just because they were getting fewer prescriptions from the ER, they were not sure or they did not measure if that meant they were getting more drugs off the streets or taking it from their family members or borrowing it or buying it or whatever. They did not measure diversion behavior. They did not measure patients' utilization of their primary care doctor instead of keep coming to the ED for help or for pain. And they said that was outside their scope. They also did not know if patients went to ERs outside the metro area, although they did make a point of saying that the closest emergency room was more than 30 miles away. They also didn't know if any of the patients filled their scripts out of state. But again, they said that the state border was more than 30 miles away to Oregon. And so if you were going to fill something, you'd have to drive to Oregon. So they sort of said, yeah, 30 miles is a pretty long distance if you're going to go to those lengths. And the other thing, which I actually thought was a little surprising, was they did not collect, and I don't know why, any data on Schedule 4 meds. And when they said Schedule 4 meds, they were referring to the benzos, because not only do patients come to the ER looking for opioids, they also come to ERs looking for Xanax and Valium and things like that. So they have no data to show that just because they decreased the number of prescriptions for opioids, did that then lead to a corresponding increase in the number of prescriptions that they may have been getting for benzos. So sure, there's definitely some pockets and some holes here, but they sort of laid those out for you in case you were wondering. The next part of the review is, were the results significant statistically and clinically? Well, statistically, yes, that seems pretty obvious. Clinically, I actually think they were significant. My favorite, perhaps one of my favorite parts of the article was the ED care guidelines that are listed on page 6, which are super comprehensive and basically show everything that was included for every single one of the patients in the intervention group. So they included such things as a security summary, an opioid recommendation. So basically the opioid recommendation is don't give them opioids from the ER unless there's objective findings to substantiate complaints of pain. Okay. It has their primary care provider's phone number, clinic name. It lists whether or not the patient is in an opioid agreement for chronic pain. And it also summarizes the number of CT scans the patient has gotten in the last 3 years and how often the CT scans had significant findings. It also shows a table of all ED visits made by the patient for the past 2 years. And it also showed a statement regarding all of the recommended referrals, such as ChemDep, psych, physical therapy. And then finally, it had a list of all of their medical diagnoses and pertinent psychosocial factors. And best of all, because they used this system called ED, which I will explain in a second, but because they used this ED system, whenever one of the patients that was in the study popped up, the ER care guideline was faxed and on the patient's chart within 3 minutes of their arrival to the emergency room. So that sort of knocked my socks off a little bit. And then I also thought it was clinically significant that the care coordination was so in depth. So they called the patient and said, okay, you're enrolled in this and we're going to watch you. They called the primary care doctor by phone. Every patient was discussed at a multidisciplinary meeting. That's how they created the care guidelines for every specific patient. As I said, the guidelines were faxed to whoever the ER physician was within 3 minutes of the patient's arrival to the ER. The ED case manager, who seemed to be the person that was the glue that held it all together, actually arranged for specialty referrals and primary care follow-up and tried to meet the patient in the ER every time they showed up. Now, obviously that didn't happen 100% of the time, but that was part of their job, was to try to capture that person during their visit to the ER. And then finally, and this is fantastic, if the ER doc for some reason did not follow the guideline and they had a researcher that was looking at the records every month to see if the guidelines had been followed, then the case manager actually called the ER doc to encourage them to follow the guideline. So again, I was like, wow, that's super detailed stuff. So then the next section is this going to change anything I do? Is this going to change anything I recommend? And for me personally, I'm not an ER doctor, so it may not change anything that I do with my patients, but my plan, after having read this, is to share the article with many of my emergency department colleagues at UH, as well as some primary care folks and some psychiatry folks, those of whom are working very heavily with care coordination, and to use it as an example of success. And I am also very interested in the ED internet-based application. So my only other comments, and again, I'm really interested to hear other people's points of view and what they gleaned from the article, is that according to the author's knowledge, this was the first ever randomized controlled trial that showed the effectiveness of care coordination in this setting. And like I said, ED or EDI, or I don't know how you pronounce it, stands for the Emergency Department Information Exchange. It is an internet-based app. What I don't know, I didn't have time to look it up. How much does it cost? How does it work? And just because I don't work in an ER doesn't mean that having an app or a similar app wouldn't be helpful to me and many others of us who work in the mental health and addiction field. And so again, I just really appreciated the sophistication that they had. And again, it's a nice example of, if you've got money to spend and you spend it in the right way, you can actually get some of the outcomes that you want, as opposed to treatment as usual, which tends to be a lot more of, which tends to look a lot more like the east side of Cleveland roads versus the west side of Cleveland roads. Thank you very much, John, for that picture that you sent. Yes, that actually is a very apt analogy. It looks like a pile of spaghetti sometimes, as opposed to a nice little grid. So, so yeah, that is what I have for you. Purposefully leaving lots and lots of time for discussion, either about this article or about the, everybody can write a big X on their prescription and prescribe Suboxone. Much more exciting. So I'm going to stop sharing there and mute my mic. And
does anybody have any questions for Chris concerning